As senolytic drugs move closer to clinical reality, one of the most pressing questions in their development is how best to deliver them. Should these compounds be given systemically, sweeping senescent cells from the body broadly, or should they be delivered locally, to target specific tissues such as joints, the spine, or the brain? The answer isn't just about pharmacology, it's about precision, safety, and long-term outcomes. Because while clearing senescent cells holds enormous therapeutic promise for conditions ranging from osteoarthritis to neurodegeneration, the method and scope of delivery will determine whether that promise is fully realized or undermined by unintended consequences. Senescence is not inherently pathological. It's a natural cellular state that serves important roles in wound healing, tissue remodeling, and tumor suppression. The problem arises when these cells accumulate inappropriately with age or disease and begin secreting a toxic mix of inflammatory signals known as the senescence-associated secretory phenotype, SASP. This buildup is rarely uniform. Instead, different tissues may harbor senescent cells in varying quantities and at different stages of dysfunction. This creates a strong argument for localized senolytic strategies, ones that precisely target the tissues most affected, such as the cartilage in osteoarthritic joints, the intervertebral discs in degenerative spine disease, or specific brain regions in Alzheimer's. Localized senolytic delivery has several advantages. First, it minimizes systemic exposure, reducing the risk of off-target effects in healthy tissues. Many senolytics, such as navitoclax or dasatinib, have roots in oncology and can affect platelets, hematopoietic cells, or liver enzymes when given systemically. Delivering them locally, via intra-articular injection into the knee, for instance, enables a high concentration where it's needed and spares other organs. Second, local delivery avoids the blood, tissue barriers that can make it hard for systemic drugs to penetrate immune-privileged or poorly vascularized sites, like the center of an intervertebral disc or the brain. Techniques such as hydrogel-based slow-release implants, nanoparticles, or viral vectors are being explored to achieve sustained and site-specific clearance of senescent cells. However, localized treatment has limitations too. It may be impractical in conditions that involve widespread or systemic senescence, such as frailty, metabolic syndrome, or cognitive decline. These scenarios may benefit more from systemic senolytics, particularly those that can be taken orally or via intermittent infusion. Systemic senescence is increasingly recognized as a driver of what's known as inflammaging, a chronic, low-grade inflammation that underlies everything from atherosclerosis to type 2 diabetes. Broad-spectrum senolytics, especially if delivered intermittently, could act as a kind of cellular cleanup protocol to refresh multiple tissues at once and improve overall physiological resilience. Still, systemic dosing requires careful balance. Because senescent cells are often embedded in complex tissue niches, and some serve protective roles in fibrosis suppression or stem cell signaling, overly aggressive clearance could impair tissue integrity or trigger excessive immune responses. This is where intermittent dosing becomes critical. Rather than constant exposure, senolytics may be most effective when administered in pulses, allowing time for tissue recovery while keeping the burden of senescent cells low. Animal studies support this model. Periodic administration of senolytics like Physidin or dasatinib/quercetin every few weeks has produced sustained improvements in health span and reduced age-related pathology, without continuous drug presence. An emerging area of interest is organ-specific targeting through smart drug design. This could involve using ligands or antibodies that bind to senescent cell surface markers only found in certain tissues, like UPAR, B2M, or S-galactosidase activity, or engineering nanoparticles that respond to the unique microenvironment of diseased tissues, such as pH changes, oxidative stress, or cytokine gradients. Another promising route is to use gene editing tools, like CRISPR-based senolytic constructs, that activate only in the presence of senescence-related gene expression patterns. These methods would represent a true precision medicine approach to senolysis. Only the right cells in the right places at the right time. Ultimately, the choice between systemic and localized senolytic therapy may not be either/, or it may be both, depending on the condition. Degenerative disc disease, for example, might benefit from a combination of local disc injections with senolytics and systemic treatments to reduce whole-body inflammatory burden. Neurodegenerative diseases may one day use senolytics that cross the blood-brain barrier in tandem with lifestyle changes to reduce peripheral SASP spillover. Post-chemotherapy fatigue or post-COVID syndrome. both of which may involve systemic senescence, could respond best to full-body senolytic cycles followed by organ support. In the long run, the ability to tune senolytic therapy to the scale and location of senescence burden will likely determine how widely these therapies are adopted. The future may include a range of delivery platforms, from oral capsules and injectables to bioresponsive implants and gene therapy patches, each matched to the specific aging challenge it's meant to address. As we develop better senescence biomarkers to measure cellular burden in real time, it may even be possible to personalize senolytic regimens based on an individual's biological age, tissue vulnerability, and recovery profile. So while the question of systemic or local is central now, it may evolve into how do we best orchestrate both? A question of strategy, not exclusivity. Senolytics are not just another class of drugs. They represent a new logic of intervention. And with smart delivery, they may finally give us a tool to clear not just symptoms, but the root cellular causes of age-related decline.